Good morning or afternoon to everyone, depending on where you're logging in from. Welcome to today's webinar. I'm Elizabeth Kropinski. I'm co-director of the Southwest Telehealth Resource Center. And this is our Improving Access to Quality Medical Care webinar series, which is brought to you by the Southwest Telehealth Resource Center, the Arizona Telemedicine Program, and the Arizona Department of Health Services. We have a special co-sponsor today, CTEL, which is the Center for Telehealth
Center
Law.
for Telehealth and eHealth Law.
Sorry, I needed a drink of water right there. Center for Telehealth Law. I would like to extend a special welcome to all of you who joined today from our Arizona and our Southwest region, Arizona, New Mexico, Colorado, Utah, and Nevada. Next slide. We respectively acknowledge the University of Arizona is on the land and territories of indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. We are committed to diversity and inclusion, and the university strives to build sustainable relationships with sovereign nations, native nations, and indigenous communities through educational offerings such as this, partnerships, and community service. Next slide. Since 2011, that's going on over 10 years, it's exciting. The Southwest Telehealth Resource Center has partnered with the Arizona Telemedicine Program to bring you over 200 informative webinars like the one we're doing today. Today's webinar, as we said, is also sponsored by the Arizona Department of Health Services and the Center for Telehealth and eHealth Law. Next slide. Oh, these are the rules and regulations, and you all know them well by now, but I'm going to tell you them anyway. As you joined the webinar today, your microphones were muted. Please use the chat function of Zoom to ask questions. We'll be monitoring that throughout, and then we'll get to the questions at the end. The webinar is being recorded, and you will be able to access it on demand from our website at the Arizona Telemedicine, telemedicine.arizona.edu/webinars/previous. The URL is here on the slide, and we'll put it at the end as well. It'll take 24 to 48 hours depending on conversion rate, but hopefully it'll be up before the weekend. If you don't have anything to do over the 3-day weekend and you want to listen to it again, you can. The slides and the recording will be there. Next slide. So it is my absolute pleasure to introduce today's speaker, Ben Steinhoffel. He is the Director of Policy and External Affairs at the Center for Telehealth and eHealth Law. He has been closely monitoring the telehealth flexibilities issued at the state and federal levels and proactively educates policymakers on the benefits of expanded telehealth and its potential to increase access to care for all Americans. Very, very critical, and we love his advocacy efforts. Prior to joining CTEL, he served in the executive branch at the U.S. Office of Personnel Management, where he oversaw the Federal Employee Health Benefits Program on the agency's Congressional Affairs team. He also served in the U.S. House of Representatives as a healthcare advisor for Congressman Jim Sensenbrenner. So without further ado, I'm going to hand this over to Ben.
Wonderful, and thank you so much, Elizabeth, for the kind introduction, and for everyone for hosting me today. I'm really excited to hopefully share some information with you guys and field some of your questions as well at the end. So thank you. So I want to provide a bit of a background on CTEL and the types of research and policy issues that we focus on. CTEL is a 501c3 nonprofit political and vendor agnostic research institute. And we focus on all of the laws, policies, and regulations impacting the delivery of virtual care. Some of our members consist of large healthcare systems, medical licensing boards, large employers, law firms, and health tech companies and startups. And for more than 25 years, we've met the research needs of our stakeholders and government entities, including the White House, HHS, and Congress. And we strive to be the first call for our members and the telehealth community for any questions regarding digital health. And we're committed to making high quality, accessible virtual care a reality for all through our data and research-backed policy initiatives. I want to provide a brief little background on the types of research that CTEL conducts. And we've produced two types, state and federal policy analysis. So we do a lot of 50 state surveys, exploring state Medicaid and private insurance plans across the country. I know in October, we're going to start working on a collaborative oversight requirement survey for all 50 states for nurse practitioners, registered dietitians, and physician assistants. So we're always coming up with new research ideas and trying to best serve those on the front lines actually practicing telemedicine. And we've also been working on a pretty large data-driven cost impact research project the last few years that we're getting close to finishing and sharing with the public. And this research is unlike anything that's been done so far. We have more than 1.5 million telehealth encounters from across the country, and we're able to really analyze telehealth costs, utilization, and services provided. And I wanted to provide a little background on how we kind of got to our current telehealth landscape. In 2001, the Congressional Budget Office scored telehealth using data that was likely inaccurate. CTEL is a term that CBO's cost estimate inflated telehealth's cost to Medicare by as much as 83%. We came to this figure by comparing CBO's initial estimates to the actual cost of Medicare, and they were significantly off in their estimates. And this resulted in the 2008 passage of Medicare telehealth reimbursement restrictions and geographic requirements designed to suppress utilization and keep costs low. And so those four big restrictions include geographic restriction and zip code requirements, where the practitioner can only be reimbursed if a patient is in a geographic location or a zip code deemed rural by CMS. Telehealth up until the public health emergency was largely only accessible by rural areas. And the location of the patient was also a restriction placed by CMS. The patient had to be located in a specific originating site deemed appropriate by CMS, and it could specifically not be the home or the patient's workplace. There were also practitioner restrictions as well. CMS determined which practitioners were best appropriate to provide telehealth services. And there were also CPT code restrictions, and those CPT codes were kind of limited in the services that were allowed to be provided. So CTEL, one of our big goals is to change public policy through our data-informed research. In 2015, CTEL had a summit, and we invited congressional staff and officials from the Center for Medicare and Medicaid Services, and they cited the void of accurate telemedicine cost data and called on CTEL to undertake this endeavor. So CTEL began consulting with the Congressional Budget Office and started working on a three-phase telehealth cost impact study to aid CBO to more accurately score telehealth legislation. So in 2015, we started with a literature review. We reviewed more than 16,900 telehealth studies, and we partnered with Mercer University to do this. And we were hoping that this would be an easy project and we'd be able to come back to CBO with our findings. But what we found is that each state had different telehealth reimbursement requirements and coverage, and that there wasn't any consistent data that we could really analyze. So this started our next phase, phase two, the data dictionary. Our independent data scientists started outlining kind of guidelines for accepting data that we could share with health systems so we can actually analyze and get meaningful analysis from those telehealth data encounters. And in 2020 to 2021, we started and are close to completing our cost impact study, which we're quite excited about, and that should be published at the end of this month, or shared at the end of this month. And then we're going to start sharing it with CMS, Congress, and the Congressional Budget Office. So it's scheduled to be released this fall. It includes data from more than 1.5 million telehealth encounters from March 2020 to September 2020. And this was really the peak of the COVID-19 pandemic, when many hospital systems closed their doors to keep patients safe. and made telehealth an option available through the waivers and flexibilities granted by Congress. We've collected data from Medicare Part A, Medicare Part B, Medicare Advantage, Medicaid, commercial payers, and self-pay encounters. We also have some charity pay as well, or payments where hospital systems have covered the cost for patients. So we've got pretty much every type of insurer or payer included in our data set, and it should give policymakers a thorough analysis of telehealth access, utilization, services provided, and cost. And some of our initial findings from our cost impact study show that expanded telehealth is cost saving or cost neutral to the federal government, depending on the service area. A significant portion of the telehealth services that were provided during the public health emergency were for treating mental and behavioral health conditions. We have not seen any evidence that telehealth is inherently more fraudulent than in-person care. This is a narrative that we consistently hear from the Hill, but or policymakers in Congress, but we really have not seen any data to support that claim. With the public health emergency licensure flexibilities, we've seen a large amount of telehealth encounters occur with patients and providers in different states, which I think is quite interesting. And we're also seeing that a lot of these telehealth encounters are happening in urban or non-rural areas. And before the public health emergency, again, most of telehealth encounters occurred in rural areas. So I'd like to run through some of the sticking points that we're seeing and hearing in Congress and the administration, because CTEL is a research and agnostic institute. We're frequently asked to advise Congress or kind of answer questions from policymakers and their staff. And we've kind of seen three recurring themes. The Democrats seem to be very concerned about reducing health disparities. They don't want to expanded telehealth to exacerbate any existing health disparities, and they don't want a system where people have access to telehealth and people do not have access to telehealth. We've seen telehealth being addressed during the broadband debate as well, and I know there's a large infrastructure package being considered by Congress right now, and digital literacy remains an issue. They cite the lack of data that we have in urban areas on people who have access to smartphone technology or laptops. They also don't want people in rural areas to not be able to meet with their doctor because they don't have broadband access. We've also heard, mostly from Republicans, lots of concerns about fraud, waste, and abuse. Again, this is something that we haven't seen much data on. Of course, there's bad actors that try to scam Medicare and healthcare programs, but we don't think that telehealth is inherently fraudulent, and we have not seen any data to support that. One of our big concerns is that some members of Congress and some on the Republican side have been fighting to put a 6-month requirement in for individuals to see their doctor in person before they're able to receive virtual care. And we think that this is a real barrier to care. And it's an extra step for people, especially in rural areas, if they need to go drive 30 minutes to see their physician, that in-person requirement can be a real barrier and prevent them from seeking care. We've also heard a narrative coming the last few weeks that expanded telehealth might be an additive versus substitutive service. I think one concern from CMS and in Congress is that physicians might do a telehealth service with their patient and say, yes, you need to come and see a person. You need to come see a physician or provider in person, and they double bill for that. And again, we're hoping that this is something that our telehealth cost impact study can point to and say that expanded telehealth is a substitutive purpose or a substitute service. And in many situations, it's best to see a physician virtually versus in person, especially given a lot of the physician and provider shortages occurring across the country. And also in terms of some sort of legislative package moving within the next few months, we've heard that the House Ways and Means Committee is in the process of putting together some sort of telehealth package. Unfortunately, I do not have a crystal ball, and I don't know when it's going to pass, but we have heard that it's likely that it could be included in some sort of end-of-year package. We've heard a lot of support for including provisions to eliminate the geographic site and zip code restrictions, and to allow the patient's home to be an originating site. They also want to expand access of distance sites in rural health clinics and federally qualified health centers. And they want to allow the HHS secretary to waive telehealth restrictions during times of public health emergency. So I think those three big provisions are likely to hopefully be addressed by Congress in the coming months. I know that payment parity and some of the reimbursement questions continue to be debated by both CMS and Congress. And I think that the Medicare physician fee schedule extends most of those waivers until December of 2023 to allow Congress and the administration to continue to collect data and analyze the best path moving forward. Perfect. So next, the proposed 2022 physician fee schedule. Hopefully you guys have had a chance to review this. CMS's deadline for submitting comments is September 13th at 5 p.m. So I encourage you all to review, especially the telehealth and virtual health provisions and submit comments. The proposed rules would make some of the telehealth flexibilities issued during the public health emergency permanent, while extending most others until 2023. And again, we've heard this consistent call from data from both CMS and Congress. And I think they're going to likely take this opportunity to do some temporary extensions of some of the waivers to allow them to get a better sense of services provided and utilization and cost. Again, CTEL's research should be coming out in the next month. That should provide a pretty detailed analysis of this all, but I'm sure that they're very, very concerned about the Medicare Trust Fund, as well as utilization moving forward. I think some of the most significant telehealth proposals that were included in the Medicare physician fee schedule are in the mental and behavioral health field. We've heard from lots and lots of providers that there's a real benefit to providing virtual care for mental and behavioral health treatments. There's a reduced stigma of receiving help. Also, physicians and providers are seeing lower missed appointment rates as well. And they think it's helpful to be able to see the patient's home, and they're able to reach more patients as well. And there's also a new category of CPT codes called remote therapeutic monitoring. And I think CMS is really interested in expanding remote patient monitoring. And so the RTM codes give patients an additional opportunity to hopefully treat more patients and provide more services. So on the mental and behavioral health aspect of the proposed rules, the proposals would remove the geographic site restrictions for telemental health care. It would also allow the patient's home to be considered an originating site as long as the patient and telemental healthcare provider meet in person within 6 months of beginning telehealth services and at least 1 month or at least once every 6 months after. Again, CTEL does have concerns with the 6-month in-person requirement. We think it can be a real barrier to care for those, especially in rural areas. And we've seen a lot of benefits of expanded telemental health treatment. And from our understanding, this provision has been included to try and reduce fraud, waste, and abuse, and to make sure that patients and providers have a face-to-face encounter in order to establish that patient-provider relationship. Another provision that CMS is proposing to expand is telemental healthcare and audio-only services. It amends the requirements for interactive telecommunication systems to include audio-only telehealth when used for the diagnosis, evaluation, or treatment of a mental health issue in a patient's home, and request comments on whether a different interval may be necessary or appropriate for telemental health services furnished through audio-only communication technology. One component of this rule that I think is interesting is it really gives the patient the choice or ability to determine whether they want to meet via audio only or audio video. The patient is able to do audio only if they either don't have access to technology or if they just feel more comfortable and would prefer audio only. But that's not something that the provider can dictate. And it also seeks to expand telemental health in underserved areas, specifically at federally qualified health centers and rural health clinics. Wonderful. And there's also a new category of remote patient monitoring or remote physiological monitoring in the proposed rules. And it recommends adding a new category of CPT codes called remote therapeutic monitoring, or RTM. The new codes would give providers additional opportunities for reimbursement in RPM programs. The RTM codes cover patient data such as musculoskeletal system status, respiratory system status, therapy, medication adherence and response, and pain. And CMS is proposing having payment parity with the current remote patient monitoring codes and to pay at the same rate. And some providers have been critical of the new RTM codes. They argue that the codes are too similar to the new RPM category and additional guidance is necessary. A big concern from providers is they don't want to get audited for providing both RPM and RTM. It seems like the intention from CMS is for these codes to be used hand in hand and together, but the codes are very similar. So there is some concern. So I'd recommend you look into it and submit comments if you're interested as well to hopefully get some more guidance on how to use those codes and in what situations. So I also want to take the opportunity to provide a bit of an update on what we're hearing with the National Public Health Emergency. On July 20, 2021, HHS Secretary Xavier Becerra extended the National Public Health Emergency for an additional 90 days, meaning that telehealth and other waivers and flexibilities that have been implemented will remain in effect until at least October 20, 2021. The HHS Secretary is also expected to extend the National Public Health Emergency order until at least December 2021. There's a lot of uncertainties happening right now across the country, especially with the Delta variant. And the public health emergency allows states to have access to additional resources for expanding vaccination programs and also responding to the Delta variant as well. And the proposed Medicare physician fee schedule rules would also extend most waivers until at least December 2023. So hopefully that does provide providers and health systems with a bit of reassurance that some of these flexibilities will be extended. But with that said, unless there's a legislative fix or if they don't go through with the Medicare physician fee schedule, many of the waivers and flexibilities that we've been able to take advantage of the last year and a half will return to the pre-COVID landscape. I'd also like to take the opportunity as well to provide a bit of an update on the status of the public health emergency orders across the country. Currently, 19 states and the District of Columbia have active public health emergency orders, with 31 states already terminating their public health emergency orders. And we're seeing some interesting things with some states that have terminated their public health emergency orders early. Some of their governors have started implementing skinny public health emergency orders to allow them to continue to get access to federal funding and food assistance programs and rental assistance funding as well. But the public health emergency orders, the skinny ones don't have as much teeth or provide as much flexibilities. And some governors with active public health emergency orders have indicated that they will terminate their state's public health orders when they achieve a 70% vaccination rate. And others have indicated that they'll continue to extend their orders to help curb the spread of the Delta variant. I think it's important for health systems to continue to engage with their state departments of health to see when these public health emergency orders may expire and to begin kind of coming up with backup plans or to have a plan in place. I know we've seen some states like Florida has terminated their public health emergency orders with very limited kind of guidance or warning to their health systems. So the few days afterwards, everyone was scrambling, especially with their contracts that they had in place and patient provider relationships, kind of determining what that means. So I'd encourage everyone to kind of engage with their state health departments and kind of thinking about next steps. And interstate licensure continues to be a challenge in some states. We've seen a handful of states join the Interstate Licensure Compact, but with that said, many states really guard their licensure programs and they really see it as a states' rights issue. So I know that there's been a lot of expanded use of telehealth across state lines. I know our study has pointed to that as well. And so if you're in a state that you're operating in a state with interstate licensure flexibilities, I'd encourage you to start working with the states and maybe having a plan in place. So what's next for telehealth? CTEL is cautiously optimistic that Congress and the administration will make some of the telehealth waivers permanent while continuing to extend certain flexibilities until they can receive additional data and evidence. As I mentioned before, the big four waivers are supported by Congress, and that would be the elimination of a geographic site and zip code restrictions, making the patient's home an originating site, expanding access to distance sites for rural health clinics and federally qualified health centers, and allowing the HHS secretary to waive telehealth restrictions during public health emergencies. But with that said, there's still a lot of question about reimbursement. And so I think CMS and Congress are going to be working hard the next 2 years, analyzing data on cost and utilization and services provided to determine kind of the next steps moving forward. There's also been a lot of bipartisan support, both at the state and federal levels, for expanding access to mental and behavioral health telehealth services. And I think that we've seen this both in Congress from members of Congress at committee hearings and some of the bills that have been introduced, but also by Medicare, by kind of expanding audio-only services and making the home an originating site. So I think mental and behavioral health is one of the clear winners of the waivers, the telehealth waivers that we've seen the last few months. And I think that the telehealth community should continue to engage with their state departments of health and plan for an eventual end of telehealth flexibilities. We've seen at the state level, lots of states have really done some phenomenal work on expanding access to telehealth, and many have passed payment parity laws, made it easier for licensure flexibilities, and really expanded the services that can be provided via telehealth. But with that said, there's still a lot of attention on Medicare as well. So I think it's something that you should be engaged with both at the federal and state level, and try and come up with a plan for the next few months and year as some of these waivers might begin to expire. Wonderful. I'm a little bit early here, so maybe I'll hand it off for questions.
Great. No, thank you. That was a wonderful presentation, and we do have a number of questions. Before I get to the questions, let me also introduce Tara Sklar. She's a professor of health law at the University of Arizona. She is also director of health law and policy program, is an Arizona law faculty senior advisor for telehealth law and policy. as well as a member of our Arizona Telemedicine program. And she's the College of Medicine Faculty Senior Advisor for Innovations in Healthy Aging. So she's going to be available potentially to ask and answer questions as well. So welcome both of you, and let's get right into the questions because we do have quite a few. Oh, let's see. The analysis that you were talking about, is it going to be available to the public? And if so, in what form and how, when, and where?
It will. So CTEL has been working with 2 independent data scientists the last few years, and they're getting close to finishing it. They've kind of cleaned up all their data. They have more than 1.5 million encounters. And currently they're kind of working on analyzing their findings, and they should be completed with that by September 30th. So the end of the month, and I'd imagine maybe a week or so afterwards, they're going to be drafting some position papers. And then once that's done, hopefully very early October, that is something that should be publicly available. And we think this is not only a resource for Congress and the Congressional Budget Office and HHS CMS, but we also think it'll be beneficial for health systems and providers as well. With more than 1.5 million encounters, we can really kind of tap into the types of services that were provided, the types of payers. So we think this is extremely helpful information for the entire telehealth community. As I mentioned before, CTEL is a nonprofit agnostic research institute. So CTEL hasn't received any funding or hasn't profited off of any of our research findings at all. So this has really been a collaborative effort from the telehealth community, which is fantastic. And we really want this to help kind of guide decisions at both the state and federal level, and to really kind of move our entire industry.
Yeah, no, we look forward to seeing that. Were cost savings, for example, travel costs and improved access to care for patients, part of that analysis?
I'm sorry, can you repeat that question?
Yeah, were cost savings such as travel costs and information about improved access to care for patients part of that analysis?
It is, yes. So the analysis, I believe our independent data scientists can include transportation costs to seeing their providers. That's something that I believe they have data that they can kind of cross-reference from the Department of Transportation to see how far patients had to travel to go receive access to care, which I think is extremely helpful for rural areas. We can kind of compare it, I believe, before the pandemic to during the pandemic as well.
Great, thank you. Is there anything in there on asynchronous telemedicine, or is that not part of it, or is this all just real life video?
Asynchronous, so that would be like store and forward and remote patient monitoring.
Store and forward, remote patient monitoring, things like e-communication through portals. I mean, it kind of covers a whole host of things. Basically, anything and everything that's not live interactive video like what we're doing.
Sure. I don't want to misspeak, so I can't confirm that. I can certainly check in with our data scientists and see if that's something that they'd have access to. I know CTEL as an organization has done a lot of work on remote patient monitoring, and we're actively always engaging the administration and Congress on RPM matters. I know just a few months ago, I believe in June, we issued a 50-state report on RPM services across the country, and we really go into detail on what's reimbursed, the services provided, and who can provide services as well. But again, I'd have to check with our data scientists. I don't want to misspeak on that front, but thank you for the question.
I'm going to go off on a tangent, and this is for both Ben and Tara. So a lot of, there's 2 different types of remote patient monitoring. One is when the provider actually prescribes something and says, okay, here, take home this EKG monitor, or, use your smartwatch. I'd love to get the data, take your blood pressure, here's a cuff, take it home. And then there's the data, and that's sort of the, official prescribed type data. And then you've got the patients who have their smartwatches, who have their home blood pressure cuffs, and upload everything into the portal and say, hey doc, what's going on? What's sort of the take on all of that in terms of sort of the provider's responsibility for that second type of data Is there any progress on definitions around that? Because that can be very confusing for providers in terms of, what is their responsibility for looking at data that they did not request?
And just to add a even finer point on that, a lot of those devices aren't actually regulated by the FDA either.
Oh, none of them, yeah.
So just to add to that point, but I'll let Ben address it, and I have an additional thought after that I'd like to bring up.
Sure. I think one thing that I found most interesting, which might be obvious from that 50-state survey on RPM that we put out, is each state defines RPM differently. So you really have to look at your statute and state regulations. I think to get an answer for that. Some of them have kind of blanket definitions, and others have very specific definitions as well. So I think it really does vary across the country.
I have a fascinating area to look, especially the latter, and that how private companies are getting so active in the game, particularly with Amazon and Withings and all the different monitoring devices. And I think this has really interesting implications for long-term care and how that's changing in our country as well, because as individuals aren't going to go, can be monitored from home as opposed to in a skilled nursing facility during that interim time. Where does those put those devices and really talking to their provider? And that's a big point, because a lot of how skilled nursing facilities balance their budget is with billing to Medicare for those short stays in their facilities. So there could be a really important to watch ripple effect with how remote patient monitoring is conducted and what that means for long-term care in America. And I think it's just a really important and fascinating area to watch.
It gets even more fun when you consider the growing role of artificial intelligence and deep learning in all of this, because you've got these devices that can monitor 24/7, and there is no way any human being can pay attention to that data. And so we are seeing a huge rise in people researching ways to analyze these data and to reduce the number of false positives, first of all. And the alerts that people get from these systems when a patient just stands up and all of a sudden your heart rate goes up, and it's like, no, they're not having a heart attack, they just stood up. But the false positive as well as the false negatives, so subtle signs, as well as figuring out what is baseline. Some people's heart rate is almost always faster than other people. That's just their baseline. So it's going to lead much more to personalized, tailored individual medicine as well in the future. But AI, that's a whole nother talk.
I was really interested, though, in how Ben brought up a future study on informed consent on a 50-state survey, because I think the level of data that will now be collected with 24 continuous monitoring, 24 hours a day, level of detail to often older patients and those who care for them being filmed or recorded in the setting. So I think it's a great time to introduce a closer look at informed consent given these new devices in the home.
Yeah, I mean, the smart house, it's smart, yes, and it can record everything, but it's Big Brother-ish, Orwellian to some extent. In terms of telehealth being additive versus substitutive, couldn't medical reviews address that concern where a telehealth followed by an in-person is more appropriately reported as a virtual check-in covered service or not separately billable because it leads to an in-person visit?
That is a great question. I think that's something CMS and Congress is still evaluating as well. Let's see. Sorry, I'm collecting my thoughts. Yes, additive versus substitutive. I think Congress is very interested, and CTEL did have a conversation as well with the Congressional Budget Office a few weeks ago about our data, and they had several questions about telehealth being additive versus substitutive. They were trying to ask if you have two patient settings or two of the same patients, one has access to telehealth and one does not have access, how do their outcomes differ? They were also very interested in kind of comparing telehealth pre-COVID to after COVID and during COVID. And that's kind of a challenge because during the coronavirus, telehealth is really the only option for most people. So these services might not have been provided if it wasn't for telehealth. So it's kind of hard to analyze if it was substitutive or additive as well. But that's something that I know our data scientists are trying to figure out, and they're coming up with some creative ways to analyze our data. And I think that's something that the Congressional Budget Office is struggling with and is kind of looking at Medicare data as well to point to.
Great, thank you. Somebody's looking for names. So who are the Congress members that are leaders on this? Senators, Congress? So not necessarily that everybody's not on board, but who are the key folks that are really our telemedicine advocates?
Sure. I'd say one of the largest bills that has received a lot of bipartisan support would be the Connect for Health Act. And that was introduced by Democrat Congressman Mike Thompson from California and Senator Brian Schatz, a senator from Hawaii. And their legislation was really used as a framework for the waivers and flexibilities included in the CARES Act. So a lot of the flexibilities that we've seen the last 2 years or year and a half or so came from that bill, the Connect for Health Act. And Congressman Thompson has been a fantastic resource, as well as the senator as well. So I think they're really pushing for it. They've been involved in telehealth for many years. I think the Connect for Health Act has been introduced at least 2 or 3 times now, the last few Congresses. On the Senate side, Senator Schatz's bill, I think, has close to 57 co-sponsors, all bipartisan. So it's getting a lot of steam in the Senate. And it's got a significant portion on the House side as well. Congresswoman Matsui from California as well has also been a fantastic resource, especially on the mental and behavioral health sphere, along with the Republican senator from Louisiana. Sorry, his name is kind of escaping me at this time. But they've done a lot of work on mental and behavioral health, and for a lot of our questions, we'll go to them, and likewise, they often come to CTEL for specific questions.
I've been following the TREAT Act that Senator Christopher Murphy introduced, and it's also very bipartisan, and that basically talks about the licensing reciprocity issue. Have you been following that, Ben, in terms of why we're in this like ambiguous area of time where like some states, the public health emergency waivers have ended, but they haven't actually passed telehealth legislation, but there still is the federal public health emergency still in effect. So this would basically provide a telehealth licensing reciprocity to continue until the federal public health emergency ends. But that seems like a very popular act that a lot of legislators
Sure. Just to confirm, is this the TREATS Act? TREATS? Wonderful. So yeah, CTEL has engaged with both the House and Senate on this bill in the past, and I know a lot of our members are very supportive. The TREATS Act also kind of touches on the prescribing of controlled substances as well, which is a huge issue for the mental and behavioral health world. Being able to prescribe prescription drugs, particularly substance abuse disorder drugs and medication-assisted treatment has been a huge issue. Several years ago, a bill in Congress required the DEA to promulgate rules on the prescribing of controlled substances. That was in the Ryan Haidt Act, and DEA has consistently kind of kicked that can down the road, and then that's something that we're actively engaging Congress with. Trying to get the DEA to promulgate those rules and to ease the restrictions on providers prescribing medications via telehealth.
Great.
And it's truly a life-saving issue for many as well. We've seen obviously a lot of reduced stigma for people seeking mental and behavioral health via telehealth. I think people are more comfortable using it. Especially in rural areas, it's easier if there's one psychologist or mental health counselor provider in an hour or 30 minutes away. It's going to be a challenge for those folks to see their provider.
Great. At some point, could one of you put in the link to submit comments to CMS? That'd be great. Thank you.
Yeah, I think we did one.
Oh, Chris already did. Awesome. So to answer that question, it's folks who there's a couple of people who are asking about it. It's in the chat already.
I'll redo it too.
Okay, and she'll put it in later. So you already talked a little bit about it, but what are you hearing about the prospect of continuing cross-border waivers? And I presume that's interstate, not U.S. border.
Sure, and I think what we're hearing on that front is it really varies state to state. I think state medical licensing, a lot of states see it as a states' rights issue, which it has been pretty much up to this point and continues to be. So at the federal level, I have not heard as many updates, but some states are beginning to enter into those relationships with other states.
Go ahead.
Oh, I didn't mean to interrupt. I just think that's such a critical issue right now because we're getting into the absurd situations where mostly the patient, but sometimes even the provider is just driving across the state line to sit in their vehicle. So they're actually in Arizona. Well, Arizona is kind of a leader in this area, but in a different state to conduct an appointment with a patient, and by no means would it improve patient care to be sitting in your car just across the state line. So it's really creating absurd situations that I am glad that the media is catching on and people are talking about.
Now, great point there. Did your study look at how telehealth has affected positively or negatively community health services, particularly in urban areas?
Yes, I believe our data can point to that. We have data sets from both rural and urban areas where we're able to see what services were provided and who utilized it as well. So I think that's something that we will be able to point towards. Excellent.
And I think you already addressed, there's a question on the Ryan Haight Act, but I think you already addressed that. Basically, it was asking, how do you think telehealth companies can navigate the provisions there after it's over? But I think you addressed that, unless you have any further thoughts on that.
I would just say continue to engage with your members of Congress and bring the issue to their attention. I think it's crucial. I think there's a lot of education that needs to be done. So I'd continue to engage.
No, perfect. Thank you. About audio only. This is always a big question these days. Is the proposal only for mental health, or does it include substance use disorder treatment and prescribing?
That is something I need to look into the proposed rules a little bit more. Let's see, I might flip through my.
And a follow-up on that is it going to be for other services outside of mental and behavioral health as well?
So I believe the CMS rule said it was for the diagnosis, evaluation, or treatment of mental health issues in a patient's home. I would need to check if that includes substance use disorders as well.
Okay, and so presumably it doesn't apply to other telehealth services outside of mental health?
No, so CMS in their proposed rules specifically expanded audio only for just telemental health and behavioral health. And I believe substance treating of substance use disorders is often included under behavioral health. Mm-hmm. Again, that's something that I'd encourage everyone to look into, and I can look into as well. But CMS might have been vague on that, but I would need to double check before I speak. I don't want to share any bad information.
Perfect, thank you. Are the new RPM codes proposed for RHCs, FQHCs, or is it also considered to be part of their AIR PPS rate?
I am not as familiar with that. I'm not sure if you guys, any of the other panelists have background on that.
We are hosting another webinar, office hours, next Wednesday with Carol Yarborough, and she really knows about a lot of these codes and stuff. So you might want to reserve that question for next week if Tara or Ben can't come up with an answer right now.
I would encourage folks to attend a code with an expert in coding for that one. And I'm sure Chris can put it in the chat, the link to attend that webinar, which I will also attend.
That's right. And I know CTEL really relies on Carol Yarbrush. She's a fantastic resource and one of the smartest coders that I know. So please tune into that. She's fantastic.
Cool. Okay, this is going to get into philosophy. So pull out your undergraduate philosophy hats. Can you explain the difference between telehealth and telemedicine and why sessions conducted via phone are more prominent?
I have seen those two terms used interchangeably, telehealth and telemedicine, both at the state and federal level. That's part of the reason why I think we did our data dictionary is people define telehealth definitions differently, different terms. I'm not sure, maybe Tara or Elizabeth can kind of speak to those two differences, but I have heard those two terms used interchangeably. And what was the latter part of that question again?
And why sessions conducted via phone are more prominent these days?
I can touch on the latter at first, because that one that really drew me in, and I think it's such a timely topic given the latest infrastructure bill. So I think that's a real reason for why there's so many, one of the major reasons why audio is as prominent as it is. It's a limitation on broadband and access to the internet. And if you want to talk to your provider, you only have so many options. So that leaves audio. And I think the community health centers have been putting out a lot of information about how that has been really key to reaching out to their patient population that could be either underserved or in a rural area. And then I think, you know, if this 65 billion for broadband comes through as part of the infrastructure package, maybe that would change going forward if there really could be greater access to broadband in more rural areas. But I think that's been a critical issue, but I welcome your thoughts on why audio seems to be so much more popular.
Sure, I'm happy to speak to that a little bit. I know when HHS Secretary Becerra was first nominated and accepted his position, he said that everything the agency does is going to be rooted in health equity and to reduce disparities. And I think that access to broadband is a real issue, especially in rural areas. My family's from Wisconsin, around the Milwaukee area, but some parts in northern Wisconsin, there really is some serious broadband shortages. So I don't think that they want a two-tier system of the haves or have-nots, people with broadband access that can meet with video and people in rural areas that don't have access. I think audio only has also been advocated for as well in urban areas as well. I think that there's a lot of challenges with digital literacy, particularly with the elderly not knowing how to use a smartphone or not having access to a laptop with video capabilities that still need access to care, and also people being able to afford that $1,000 computer or that cell phone with a front-facing camera on it as well. So I think patients and providers both get a lot out of audio video, and I think Congress and the administration are pushing for that if that's an option, but they don't want people to not be able to meet with their doctor or those that are in underserved communities to be disadvantaged because they can't see their doctor virtually.
Yeah, and with respect to the differentiation between telehealth and telemedicine, most people still use it interchangeably. Technically, telemedicine is the delivery of clinical services, whereas telehealth is a broader umbrella term that also incorporates education, training, administrative, and other aspects of providing healthcare, virtual care, connected care, remote patient monitoring, mobile health, e-health. You could go down a wormhole. Basically, a lot of us in the field would just love it if people would just call this healthcare and forget about all this tele stuff and whether it's health versus medicine and all that. It's just another way of delivering care. But we got what we got, and for the most part, they're all interchangeable. I mean, unless you're, somebody into semantics, it's just another way of delivering healthcare. But that's my personal opinion.
You know, it kind of gets back to this idea of what is healthcare and this evolution, you know, well, oh no, it's that direct interaction, you know, on a specific diagnosis for an illness. But now when you bring in social determinants of health and all these other factors, then you see it's much broader than how we use like the traditionally perceived medicine and healthcare in general. It kind of tracks that same evolution.
Yeah, no, it's a fascinating topic, and there's a lot of great papers on it. And I'm actually on another committee now with IEEE, the International Electrical Engineering Group, who are working on another lexicon about what's telehealth and what's not, but we'll see. Would the Medicare 2022 fee schedule proposal requiring in-person visits for telemental health start January 1, 2022, or would it be delayed until 2023 to maintain the PhD standards as they are?
Fantastic question. I would need to check in on that. I don't want to misspeak. I don't have the rules pulled up here, but that's something that I should look into.
All right, thank you. We are running out of time here. We only have about 4 more minutes left, and there's a ton of questions left. So we can't obviously address them all. So let me just kind of pause here and say that what we're going to do is we typically after the meetings, we'll download the chat. We'll get Ben and Tara, if she's willing, to help answer some of these. And then we send them all the answers out to everybody who's attending the webinar, because we do have your email addresses, obviously. So if we didn't get to your question, we do apologize, but I'm going to get like 1 or 2 more before we kind of close up. Where is this being voted on first, House or Senate?
So on the congressional telehealth package, we have heard that Ways and Means, Chairman Lloyd Doggett from Texas is taking the lead on it. So if there is any movement from what we've heard, it will likely come from Ways and Means. A little unclear where the Senate is on their timing so far, but Chairman Doggett does appear to be working on some sort of package. He hasn't released any text. I guess it's still in draft form. And in terms of timing, we've been kind of chatting about this with several of our members, and it obviously wasn't included in a broadband package, but we have heard that it might be included in some sort of end-of-year package, in an appropriations package. It might be something that is included. But I don't have a crystal ball, and Congress is always kind of unpredictable. But from what we're hearing, there might be something happening in a larger appropriations bill that telehealth might be included in.
Great. Well, as you kind of bring up the slides again, here's my last question. It's directed at both of you, and it's from one of our attendees. Are there specific legislative proposals which would advance telehealth eligibility? For example, no rural requirements covering home that we should be watching? In other words, from each one of your perspective, what is the killer thing that we should all be looking at and watching that's really just going to do it for us all? And again, Ben, if you could bring up the slides, that'd be great.
Sure.
So while he's doing that, Tara, what do you think?
Well, I think that is a great question. And actually, as we've been talking this whole time, I've been just scrolling through the questions, which are also thoughtful. And really, I have never been on a webinar participant or as an attendee that has had so many questions. So thank you to all our attendees, and to you, Elizabeth and Ben. But I mean, I'm a big fan of what we've done here in Arizona with HB 2454. I think it's very comprehensive, and the approach to how can we really focus on providing quality care and not barriers that may not help care at all and could potentially harm individuals' access to care. So I advocate a bill that does very similar work we've done here in Arizona. I also think the work that the Corey's done in this area, as well as CTEL, on really trying to bring the evidence to the conversation in terms of what is the savings involved when telehealth is more accessible, if it's audio only, the geographic restrictions are removed. And now that we have that real data of how that actually works because of COVID, I think that could have a real impact on what does make the most sense from a legislative and policy perspective nationwide. And also, you know, we'll have our adaptations in each state. It's just to be expected.
And what are your
Wonderful.
thoughts?
And I know I mentioned the Connect for Health Act earlier in this conversation, but I really think that that bill has a lot of steam, both in the House and Senate, with a lot of bipartisan support. And again, a lot of those provisions were kind of used as a framework for the CARES Act and the Families First Act that kind of established a lot of these waivers and flexibilities in the first place. We've also heard a lot of support from the mental and behavioral health from players for the TREATS Act as well, to loosen some of those prescribing guidelines. And Congresswoman Matsui has a piece of legislation to remove the 6-month in-person exam requirement. And that's something that we've been very supportive of. And again, we think that's a real barrier to care. It's an additional step for people to take, and we think it's got bad implications for the entire telehealth community. If Congress is saying that you need to see your doctor first, and if telehealth is truly a substitutive service, I think that in-person requirement can be a real challenge for some.
Great, thank you. Can you go up to the last 2 slides? Again, the rest of the questions we are going to answer or put up answers remotely. Next one, I think. Next one. There we go. So this presentation, again, has been brought to you by the Arizona Department of Public Health Services, the Arizona Telemedicine Program, and its Southwest Telehealth Resource Center, as well as CTEL. For upcoming webinars and events, please check out our website. And again, all of this is recorded, and it will be up on our website under previous webinars as soon as we can. Last slide. As always, we value your opinion, so please take a few minutes and complete this online survey. As you exit, you will be taken directly to it, and we highly encourage you to provide us with feedback, especially about topics that would be of interest to you. So thank you, everyone, especially Ben and Tara, for the presentation and answering as many questions as we could. It's been incredibly useful and informative. And we look forward to everybody attending again next Wednesday's webinar by Carol, which would be on the physician fee schedule and Medicare physician fees and all that good stuff. So thank you all so much, and enjoy the rest of your day.
Thank you.
That was a pleasure. Thank you.